Good morning, everybody. Thank you for coming. This is a bite-sized talk on the topic of end-of-life care. Rich Parker, Chief Medical Officer for Arcadia.
And I'm Jake Hochberg, the Executive Director of the Customer Insights team here at Arcadia.
This is a topic that is near and dear to my heart. Some of you may know that I work in hospice. I do hospice care on weekends when I'm not working for Arcadia. And I was working there this past weekend. I took care of quite a few patients at the end of life. And I just want to give you a little flavor of what good hospice care really is all about. Because there's an impression in the United States that patients often or usually die in a hospital. And that is still true, that many patients do die in hospitals. But if you ask a patient or a family member, what would your wishes be? Usually, almost always, people say, I'd like to die at home with my family present, and I'd like to be comfortable, and I'd like to have some dignity. And the good news is that's all achievable if doctors and the system that supports doctors has the tools that we need to get that work done. So I'm excited that Arcadia is doing some work in this area, and Jake and I will be talking about that today. So just as a start, on this overview, I'm going to step out here so I can see this. I mean, the most important part of hospice care is not about money. It's about excellent care at the end of life. But there is a financial implication of good hospice care. And the good news is that the incentives line up really well. So good hospice care is actually far less expensive to the system. And here's just a small illustration of that. You can see at the bottom of the screen, when people have more than 10 days of hospice, which is not a large number of days, the costs toward the end of life are relatively low. And intermediate, if they have less than 10 days of hospice care, the costs spike up to $18,000. And then if they have no hospice care, obviously it's even higher. Good hospice care, I can tell you from experience, is often more than 10 days. It might be a month, it might be 2 months, it might be 6 months, it might even be longer than that. So, Jake, if you want to just explain this part of the graph,
yeah, absolutely. So then on top of that, saying that we see across our customer base is there's a really wide spread in terms of how many patients are passing away with 10 plus days of hospice. So for some of our patients on the lower end, it's at only 17% of their patients die with 10 plus days of hospice. Whereas on the highest end, 39% of patients are dying with 10 plus days of hospice. And saying that we see a lot of is members being enrolled in hospice in their final day of life or final 2 days of life. So they're already in the hospital, they're already in the ICU when this is happening.
Now, one of the things about this graph that I think is really important is these are our actual customers, obviously blinded. But when we have a customer who's interested in how they're doing with end-of-life care, if I ask them, well, do you know? The answer is actually no, we don't know because we don't have any data. And so one of the things we can do with Arcadia is we can get their data and we can tell them where they lie on this graph. Are you up at 39%, which is pretty good, or are you way down at 17%, which means there's a lot of room for improvement? So this is beginning to show you the power of the data to show customers where they start with end-of-life care. The implication being the more days, the more patients in hospice care, the better they're doing. Sure. I think we can go on.
So as we move forward, we can talk a little bit about how can we actually help our customers. So on top of being able to give those benchmarks, showing you where you stand against other customers, we do have some tools in our suite that can really help. So first off, we have a dashboard that allows you to determine the level of investment that might be right for you in end-of-life care. So not only is it better for patients, but as we showed on the last slide, if a member's enrolled in hospice for more than 10 days, that's going to save about $15,000 in medical expense. So we can give you the ability to start to model out, if we were to invest in an end-of-life program, how much is that potentially worth to us? On top of that, we have the ability to explore provider-based utilization in hospice care. Something I've seen is often there's a few outlier providers within any network that have almost no hospice utilization whatsoever. So there's an opportunity for some physician education in those spaces. Lastly, we use predictive analytics. We have an algorithm that is tuned to identify members that are at high likelihood of passing in the next 6 months. That can help you identify patients earlier in the process, get them in, do advanced care planning visits, start to have those end-of-life conversations early so that patients are more ready to transition into hospice when they're ready.
Yeah, I would just add that good hospice care is a whole program that the customer needs to take on. So they can't just say, we want to do it. They have to have the leadership, probably have a palliative care doctor half day a week to advise the program, an education program for physicians, so they are in the program with who is eligible for hospice, and then of course having adequate hospice available in that geographic area.
So I'm going to talk for a moment about our end-of-life algorithm. Again, this is built to be able to put registries in front of providers so that on a monthly basis, they can review the patients who are at the top of this registry, outreach to a small number of members, but have a really large impact. So for our end-of-life algorithm, we include utilization, HCC conditions, demographics, and SDOH information to predict which patients are of high likelihood to pass away in the next 6 months. When we look at the actual model results, something that we can see is 25% of members that are going to die in the next 6 months are identified in just the top 4% of the population, meaning that you can outreach to 4% of your population and have outreach to 25% of members who are ultimately going to die, and do that early outreach to try and either enroll patients in hospice or start those conversations. Additionally, 36% of all members who are going to die are in the top 10%. So again, you're able to outreach to a small portion of your population, but really identify the right patients to speak to.
Yeah, and I'd like to comment how this works from the doctor's perspective. So if you're a family practitioner or an internist, you have an average panel of 2,000 patients, that's full-time. And if you say to that doctor, tell me who are your patients who you think are eligible for hospice in the next 6 months or next 12 months, you're going to get a blank stare because our brains don't work that way. But on the other hand, if you take the Arcadia algorithms, you run their data, you give them a list of, say, 100 patients, and you say, no, of these 100 patients, which do you think will be eligible for hospice in the next 6 to 12 months? They're going to know, because these are the patients that come in frequently. They're sick. They have multiple comorbidities. And so by combining the Arcadia algorithm with the doctor's brain, you're going to end up with the right list of patients to put some more effort into.
Absolutely. Also add, you can use this list to identify the patients that are slipping through the cracks. So something we've seen is a decent number of members that are nearing end of life, but they're bouncing in and out of acute facilities, ER, SNF. They're not having a strong relationship with a PCP. This can help to identify those patients earlier. You're more likely to enroll them in hospice in that way. Moving through the model, also from a mortality perspective, members in the top 1% of the output of this model pass away 12.4 times more likely to pass away than members not in the top 1%. And members in the top 10% are 3.4 times more likely to pass away than members not in the top 10%. So you really are identifying members that are at a much higher likelihood of passing away. And even if they don't die in the next 6 months, it's still useful to start those conversations. These are members that are likely to end up on that path in the next year or two.
Just by way of information, in Medicare, the rule for hospice eligibility is the assessment that a patient will die within the next 6 months. But if it turns out that they don't, Medicare is okay with that. So we've seen patients go on for quite a bit longer than the 6 months, sometimes 12 months, 18 months, even 24 months. And that's fine with Medicare, as long as the assessment was they only had 6 months to live.
And that's it. Does anyone have any questions today? But the question was basically, where do you start? How do you start a hospice program? How do you start an end-of-life program? So from my perspective on the data side, part of it is just identifying where do you stand compared to your peers, which providers need the most support, how do you identify the right patients. Once you've done that, it's about rolling out the program and provider education more than anything else, especially if your program is going to rely on PCPs outreaching to patients.
I would just add to that it starts with leadership. So an ACO has got to make end-of-life care a priority and put the muscle and the money and the strategy behind it. If they don't do that, it's not going to happen. If they do it, it still might not happen, but it's necessary. And then they need to have a physician champion, preferably a palliative care hospice physician who's knowledgeable in this area that can take the lead in educating the doctors and other providers in the network. And then, as Jake said, using the data to figure out where are you now, what's your benchmark, what's your starting line, what % of your eligible patients are dying with fewer than 10 days of hospice care, measure it, and then start rolling out the education process, remeasure in 6 months, remeasure in 12 months. And the good news I can tell you from experience is that I've seen a network go up substantially over 1 year from something like 39% dying with hospice to up to 52%. So even in 1 year, we've seen substantial improvements. So this is a program that we're very energetic, enthusiastic with our customers, saying this is something you can do it well, it improves patient care, and it's also good for your budget. So thank you. That was a long answer. Thank you, Lenny. Any other questions about hospice, end-of-life care?
Sorry, what? For the algorithm? So the question is, where do we get the SDOH data for the algorithm? In this case, we're using a combination of census block data, and we are looking for, there's a specific Z code for lack of social support that we find is actually really highly correlated with the likelihood of passing. So when patients are coded as lack of social support, that it increases their odds in our model. And we do that from ICD codes.
Other questions? Yes.
Can I see the slider, the first slide?
Yeah. If I can find it, yes.
No, the first one.
Slide 1.
Yes, yes. I'm curious that what is the main reason for the second stick is the higher than the first stick. I think that is the money per day, so it is depend on the hospital stay. Stay of hospital is determine the money per the day.
That's right. So for most patients in this bucket, there is no large hospital stay at the end of their life. And for most patients in both of these two buckets, they're in a hospital. So there's an extra hospital stay basically as they die. So that's where and that's about $15,000. So that's why there's typically that variance there. There's also a visual around the corner that has some more information on like the spend per day and how that breaks out. But what you'll see is for the final 10 days in no hospice, most patients are dying in the hospital.
But my opinion, I think for the patient in the stay in the hospice, then that it is very important to the patient for that is a quality of life or the how can control the pain. That is the more important things to that patient.
Oh, absolutely.
Yeah.
Yeah.
Not the money.
No.
Yeah.
Now, I think the money helps to drive investment in the space because there's a reason to do these programs on top of just the moral reason and the fact that's better for the patient. But as Dr. Parker said at the start, most people, if they had a choice, would prefer to pass away at home in hospice comfortable versus in a hospital.
Yeah, thank you for emphasizing that because that is the key point. This is first and foremost about good patient care, and secondly about finances. Other questions? Anybody? Okay. Thank you very much.
Thank you all.